Hello, Kinesiology 3030. Welcome to our lecture on the lower leg. So today we'll talk about the ankle joint, the subtalar joint, the metatarsophalangeal joints, and the interphalangeal joints of the foot to cover the lower leg and the foot. So looking at these joints, we're looking at the tibio-talar joint, which is the joint between the tibia and the talus. The talocrural joint as a whole includes the fibula because the fibula and the talus also articulate with each other. But we'll look specifically here where plantar flexion and dorsiflexion occur. We'll look at the subtalar joint between the talus and the calcaneus and the rest of the tarsal bones, where we see that frontal plane inversion and eversion occurring. And then we have our metatarsophalangeal joints and interphalangeal joints within the foot, where we can see flexion extension, as well as some abduction at a few of those metatarsophalangeal joints. So looking at how to kind of our lower leg and our foot articulate. The first muscle we'll look at is gastrocnemius. Gastrocnemius does have its origins on the femoral condyle, so it is technically a tibiofemoral joint muscle as well as a talocrural joint muscle or tibio-talar joint muscle, because its insertion is on the calcaneus through the Achilles tendon. The actions here are knee flexion, so it is gastrocnemius is a synergist for knee flexion, as well as plantar flexion during knee extension. So if the knee is in flexion, the gastrocnemius loses some of its ability to contribute to ankle joint movement because it is shortened by having its origin at the distal femur. But gastrocnemius will be a synergist for knee flexion, and if we are in knee extension, it will be our prime mover for plantar flexion. But if the knee is in flexion, then Soleus takes over as our primary plantar flexor. So knee position matters when it comes to plantar flexion function. So the Soleus has its origin on the posterior tibia and the fibula, and then its insertion is on the calcaneus through the Achilles tendon, and the Soleus is deep to the gastrocnemius, and it is our primary, our sole plantar flexor, regardless of knee flexion, knee extension. But if we are in knee extension, gastrocnemius takes over as our primary plantar flexor. If our knee is in flexion, our soleus takes over as our primary plantar flexor. So that knee position really matters. If we shift over to the anterior aspect of the lower leg, we see tibialis anterior, which has its origin on the lateral tibial condyle, as well as on the proximal anterior tibula. And then its insertion is on the first cuneiform and the base of the first metatarsal. So we're moving from a proximal lateral tibial location as our origin to a medial and distal insertion site on the end of the tarsals and the base of the metatarsals. So if we look at that kind of diagonal crossing over the subtalar joint and that anterior crossing over the talocrural joint, we can see that we can contribute to ankle dorsiflexion through that anterior sagittal plane movement, and then an inversion for the subtalar joint because it does have that lateral to medial crossing, which will give us that inward frontal plane movement or inversion at the subtalar joint. So tibialis anterior is an inverter as well as a dorsiflexor. It's our primary dorsiflexor for the talocrural joint and our primary inverter for the subtalar joint. The peroneal group, Peroneus longus, Peroneus brevis, and Peroneus tertius, are lateral muscles for the subtalar joint. The Peroneus longus has its origin at the proximal fibula, brevis distal fibula, and the tertius anterior distal fibula. And then the insertion for the Peroneus longus and Peroneus brevis is the fifth metatarsal at the plantar surface. So we're looking at plantar surface rather than dorsal surface, where we see with the Peroneus tertius, which is at the fifth metatarsal, but on the dorsal surface. Remember, plantar surface is the underside of the foot, and dorsal surface is the top side of the foot, which does matter when it comes to how these muscles are going to interact with both the subtalar and the tibiotalar joints. So the Peroneus longus and Peroneus brevis both assist in plantar flexion. All Peroneus group contributes to eversion or lateral movements of the subtalar joint. Peroneus longus as our prime mover, but Peroneus group all functioning together. And Peroneus tertius is a synergist for dorsiflexion because it does have that dorsal insertion point. It cannot contribute to plantar flexion like our Peroneus longus and Peroneus brevis, which have a plantar surface insertion site. So Peroneus group is an everter group, and Peroneus tertius is special because it is a dorsiflexor, synergist for dorsiflexion with Tibialis anterior, while Peroneus longus, Peroneus brevis are synergists for plantar flexion with the Soleus and with the Gastrocnemius. Next muscle, similar to Tibialis anterior, we have Tibialis posterior, which has its origin on the posterior tibia and fibula, and the interosseous membrane, which is the membrane between the tibia and the fibula. And then it has its insertion on the navicular bone, the first cuneiform, and metatarsals 2 through 4 on the plantar and medial surface. So this is it's a plantar muscle. So it runs on the medial aspect of really the arch of the foot to attach onto the tarsals and the metatarsals. And the action here for Tibialis posterior is 1, plantar flexion, and 2, inversion, because it does have a posterior crossing and a medial crossing over the tibiotalar and the subtalar joints. But realistically, it's working to support the body weight and create a medial arch of the foot. So this muscle really runs through that arch, that medial arch, and pulls the tarsals superior to keep that arch and to stabilize the midfoot through plantar flexion and inversion. It will work as an arch stabilizer more than a prime mover. So it's a synergist for inversion and plantar flexion and our primary arch support for the midfoot. Looking at the anterior, looking still on the posterior aspect and medial on the foot, we have Flexor Digitorum longus and Flexor Hallucis longus. Flexor Digitorum is in the hand, Flexor Digitorum longus is in the foot. Flexor Digitorum longus and Flexor Hallucis longus have insertions on the posterior tibia and the fibula. Flexor Digitorum longus on the tibia, Flexor Hallucis longus on the fibula. And then the insertion is on the plantar surface for Flexor Digitorum longus on digits 2 through 5, and Flexor Hallucis longus on digit 1, or the hallux, which is the big toe. They do all cross posterior and medial over the subtalar joint, but they do cross onto their individual digits. So what do we think our actions are here for Flexor Digitorum longus and Flexor Hallucis longus? Thinking back to how we organize the hand, Flexor Hallucis longus is going to cause flexion of the first digit. It will also be a synergist for plantar flexion and a synergist for inversion at the tibiotalar and the subtalar joints, respectively. The Flexor Digitorum longus will have similar or the same synergistic movements for the tibiotalar and the subtalar joints, but it will cause flexion at digits 2 through 5. They all also are synergists with Tibialis posterior to stabilize the medial arch of the foot, to keep the foot stable, especially with our weight being placed on the foot, especially on the midfoot. These muscles help to raise the arch and distribute the weight of the body effectively over the surface of the foot. With Extensor Digitorum longus and Extensor Hallucis longus, these are kind of like the inverse of Flexor Digitorum longus and Flexor Hallucis longus, but they do all have origins on the fibula And then the insertion for extensor digitorum longus is on digits 2 through 5, and then extensor hallucis longus on the first digit. The actions here will be dorsiflexion, eversion for extensor digitorum longus, and a inversion for extensor hallucis longus, based on the line of pull across the subtalar joint. With these, we've talked about a few fibular origin site and fibular insertion site muscles. This is one of the major impacts when the fibula is broken, or fractured fibulas. The fibula is not really a weight-bearing bone. You're not going to be placing a lot of mass or compression forces on the fibula. We feel more tension forces on the fibula through muscular attachment. So any fracture to the fibula causes an impact to how the foot muscles function, because now they have an unstable origin site. We lose function at the foot when the fibula is broken or the fibula is injured. So think of the tibias are really our weight-bearing bone, and our fibula is our extra attachment point for our movers of the foot and ankle. And this really matters, especially those muscles that like tibialis posterior, flexor hallucis longus, and flexor digitorum longus that cross over that medial arch. These can contribute to stabilization of the foot. If we have a lack of stabilization at the foot and creating that supinated foot where the arch is raised while we're in dorsiflexion, it can lead to an overpronated foot, which is where the arch collapses and the forefoot moves laterally. And then the rear foot moves into an internally rotated position, leading to leg internal rotation, and the femur adduct, and the hip internally rotates, creating a pelvic tilt forward. So when we have this collapse of the foot, we have an internal rotation of the entire leg, which forces the pelvis to tilt forward to create space for the femur, which leads to an anterior pelvic tilt. We've talked earlier about these anterior pelvic tilts, how they lead to overextension at the lumbar spine, and lead to some issues up the chain, because now we have an unstable pelvis. But this comes from an unstable foot. The foot is the only part of our body that is attached to the ground in most cases. So having an unstable foot leads to an unstable leg. Unstable leg leads to unstable pelvis. Unstable pelvis, unstable lumbar spine. Unstable lumbar spine leads to pain and lack of function later on in life. So this is something that we need to pay attention to: foot position, hip position, lumbar position. When it comes to our posture, you may have, or a client or someone you're working with has maybe anterior pelvic tilt, but it may not be because they have tight hip musculature. It may be because they have an issue with their foot, and that foot position is leading to a poor hip position. That poor hip position is leading to poor lumbar position. That poor lumbar position is leading to instability, pain, issues, and symptoms at the back or even at the neck, by causing some shift in neck position to compensate for these changes down the chain. So start from the ground, start from the foot, work our way up. If we can stabilize the foot, we can often stabilize the pelvis. If we can stabilize the pelvis, we often have a nice stable lumbar spine, and all the way up the chain through the cervical spine. So pay attention to posture of the lower extremity, not just posture of the trunk. The lower extremity does impact trunk position. All right, thank you for watching, and I'll see you in lab.